And I'm so pleased to be joined tonight by Professor Erin Morton, who is a real beacon of light and forensic interest in the field of peri and menopause. I'll give her a proper intro soon, but just want to run through what we're going to do tonight. I've managed to get a Senate inquiry established through the federal parliament, which means that there's an issue that the Senate's going to look at, and we're inviting submissions from members of the public, from experts, from academics, from employers, from women, from people with lived experience of perimenopause and menopause, to basically tell the Senate what your experience is and what sort of federal policies you think should be developed in this space. So it's a really useful process because, as you know, women's health tends to be pretty ignored. Unfortunately, we've got a history of our pain and our experiences not being heard or not having proper policy developed to cater for them. And I'm hoping that this Senate inquiry is a stepping stone for us to get a better understanding of the shape of the problem, and then also to fix whether it's workplace rights that are lacking or whether it's health treatment that's lacking, whether it's awareness that's lacking. I'm hoping we can fix all of those things. So tonight's session is basically about the Senate inquiry and how you can participate. And I'm really pleased that Professor Erin Morton is joining us as a practitioner. So if you've got any more medically oriented questions, then she will be your go-to. But essentially, as you probably know, perimenopause and menopause affects women and people who menstruate. And so I'll use the term women inclusively tonight to include people who menstruate. And menopause happens generally between the age of 45 and 60, but perimenopause, which precedes it, can last for up to 10 years and can start as early as your 30s. So we're talking a really large bulk of the population and potentially quite a long period of time. So it's really important to understand what this means for women financially, what this means for women emotionally, what this means for us in the workplace, what this means for us in our personal lives, essentially what this means and how we can better support women through this time. Essentially, women have been suffering in silence. And I do want to flag that not everybody suffers in peri and menopause. Some women don't have any symptoms at all, and that's wonderful. And we certainly don't want to over-medicalise or over-diagnose women. But for women who are struggling with peri and menopause, we want to make sure that you feel confident of what to do, where to go, what your options are, and that you can be supported in your workplace to continue with your working obligations. So that's why I've initiated this inquiry. So it's going to look at that full gamut of issues. It's going to look at the economic, the physical, the mental, and the financial impacts of menopause and perimenopause, as well as cultural perceptions and attitudes about this health issue, which affects more than half of us. And just on statistics, and Erin will know more about this and will correct me if I've got an out-of-date figure here, but 80% of Australian women experience peri or menopause symptoms that range from either mild to extremely severe. So we're talking about a very important issue here that can have really profound financial impacts. Many women are saying that they feel like they're unable to continue at work. There's some international research that shows that women are retiring more early than they otherwise might because of menopause symptoms. And so that has a financial impact. We know we have a gender pay gap throughout our lives anyway, sadly, and that culminates in a retirement income gap when women retire. And if you're retiring even earlier than you anticipated, then essentially you're in a world of pain in this cost of living crisis. So I'd like to see the Senate develop evidence-based policies that understand and reduce the impact of menopause on women's participation in the workforce, and also that make sure that when we seek medical treatment from GPs or other medical practitioners, that there's a good level of awareness by those practitioners, that there's a validation and a good treatment options outlined, and that any treatments, if you do need medications, are actually affordable and that they can be a real solution for you rather than an unaffordable option that you then have to do without. So that's a real summary of why I've initiated this inquiry. And as the women's spokesperson for the Greens, I get to do wonderful things like this. And I'm really hopeful that the inquiry will be a great success. But that'll be up to you So I'm so keen to hear from women and people with lived experience about how you've experienced perimenopause and menopause. If you've had a great time, wonderful. We want to know that too. If you've struggled, if you've had a tough time, we want to hear about that. We want to hear about those impacts on you physically and mentally and emotionally. We want to hear, did that have an impact on your workplace? Did it have an impact on your relationship? We really want to hear those life stories of what this means for ordinary people, because here as legislators and lawmakers, it really helps when you're crafting a policy or a law if you've had the benefit of lived experience or somebody has shared that experience with you. So this Senate inquiry is not just for the experts, it's for ordinary people as well, and we're desperate to hear from you and your experience. We also want to hear from health practitioners. We want to hear from workplace experts, whether they're employers or workers. We want the full range of input. And what we don't have a great availability of yet is excellent data. And there's some international data which suggests this is a problem. There's some national data that's a little bit old now, a few years, that says 83% of respondents said their work was negatively affected by peri or menopause, and almost half struggled with a drop in confidence at work. Almost half felt stressed by having to hide their experience. A good third of people said they felt disconnected or distracted from their workplace, and almost half of respondents said they were considering retiring or taking a break, but most people, of course, couldn't afford to do that. So the data gap is really significant as well, and that's maybe something that government can help with, is, you know, funding the collation of that data in order to develop good policy. So what we're going to do this evening, now that I've given you quite an extensive intro, is we're going to hear from Professor Morton, who will talk about her work and her experience and hopefully the things that she is hoping for out of this inquiry. But we're also just going to run through the terms of reference for the inquiry and make some suggestions for the things that you might like to share. And at the end of the night, we're going to put up a link that is to a web page which has got essentially like a cheat sheet, a helpful guide for how to make a submission. It makes some suggestions about the sorts of issues you might like to talk about, and it also will run you through the process of how to do the submission. There's a couple of steps involved, but it's not too daunting. You've really just got to click on a link, get a registration, and then upload your document. And what I want to make sure you feel comfortable doing is a submission doesn't have to be formal. It can be an email that's a paragraph long. It can be, you know, your thesis if this is your area of expertise. There really are no rules for what form a submission needs to take, as long as it's what you want us to know about. And it can be as formal or as informal as you feel comfortable sharing. If you want to put in a confidential submission, you can do that too. You can ask the Secretariat redact your name and your contact details so that the information still comes to us, but your identity is your own business, if that's what you'd like. So yeah, don't be daunted by the process, and don't feel like this is some, that there's some great requirement for verbosity or for, expert qualifications. We do want to hear from experts, but we also just want to hear from ordinary folk with lived experience. So I will stop rabbiting on, and I'm going to pass over to Professor Erin Morton, who's been a medical researcher for over 20 years. She's worked on international and national clinical trials and health data to improve community health outcomes. And despite this wonderful and learned background, perimenopause hit her for 6 in 2021, and she was confronted by how little she knew, clinicians knew, the community knew, researchers knew, workplaces knew about this stage of life, which is certainly a story I've heard a lot too. And she was really concerned about the lack of knowledge and support available for the sheer range of symptoms and intensities. And so Erin decided to apply her research experience to create a consumer-driven, community-led national peri and menopause registry called Vital, which is a virtual registry of menopause and perimenopause in Australia. It's composed of carefully chosen questions, prioritising what the peri and menopause community thinks is most important. And she's also got an amazing new development that she's going to run us through that's just happened earlier today. So I'm going to hand over to Erin to to share, and then we're going to hear from you. So please get the chat box ready or get your Facebook comments ready, and either Erin or myself will do our very best to answer your questions or just to share your experience with the group of people who've joined us tonight. So please welcome Professor Erin Morton. Over to you.
Thank you so much, Larissa. Hello, everybody. I do consider myself very lucky to speak to you today. I'm very much someone who's wearing multiple hats. As has been mentioned, I'm a medical researcher. I also hit peri a few years ago. My prior research area was not peri or menopause, but at the same time, as you might imagine, we all tend to be pretty blunt about our bodies, about biology when you work in my field. And so in some ways it horrified me even more that there was just no discussion, and it very much became I guess a matter of interest to me that the more I looked for help for myself, the more I spoke to other people, despite, as I'm sure a lot of people also feel, the stigma and the vulnerability about saying something, particularly in a workplace or where you feel you might get judged. But once I started speaking, more and more people did. And I was incredibly lucky in reaching out to people literally across the country who had no idea who I was. But there's this momentum at the moment, and that's part of why I'm here. I really, really want to encourage exactly what Larissa said, as many submissions as we can. Doesn't matter how we say it, and I will probably flick a little bit in the way I'm speaking tonight in terms of the way I'd speak to my friends and the way I'd speak at work. Please call me on it if you can't hear me on that. But yeah, I guess just as a bit of background, when I look at it as a researcher in clinical trials for decades, all medicines, all devices were only ever tested in men, because they didn't want to deal with the hormonal changes that admittedly will affect the way medications affect women. Then they got to a point where you could only have it if you knew exactly when your cycle was, and so everyone was at the same stage. But then the fact is that these medicines would be released out in the world, and millions of us would take it without that actual testing on ourselves. So as a scientist, I guess I understand what the background is, but it's also the same thing in any level of research, in that obviously the more research that's done globally, that's wonderful for the community, but also it means that a lot of research goes down into particular niches. So they might be ones where funders are interested, they might be ones where there's a local population, it might purely be to do with the interests of the researchers and the clinicians behind it. But I found when I was starting to look, when I clued in that my issues were peri-related, there was a lot of information about hot sweats and certain levels of information about other things, but I struggled to find information. I could find sort of the front web page at Mayo Clinic or places like that. And then even with access to all the journal articles that you may only get being in an academic sort of area, I still couldn't find information, or certainly not enough that made me feel like I had a proper understanding. So I was going to my GP and clinicians that I work with going, hey, any chance you can, explain this in plain English, or tell me a bit more about this, or do you know if anyone's doing something in this area, even if they hadn't published things? The critical thing about any research, including not just my own, but any research, is it is determined by who we include. And that's what I, again, really want to emphasize. If we don't all speak up, or at least as many of us as possible, it's not even considered. And in something like perimenopause, where it's not just one symptom, and we're not just in one situation, whether we've got family, whether we're in metro or rural areas, whether we've got other commitments, whether even if something as, well, not necessarily simple, but technological access, so whether we can access telehealth or something like that. All of those factors come into it. And again, with the stigma behind things, what we don't necessarily say So sharing for myself that my big symptoms were mental health related. I had depression for the first time in my life. My brain fog was ridiculous. Could not think of the words that I was looking for, which sometimes comes back. But that, again, increases your level of vulnerability. For fairly obviously, I do a lot of work behind a computer. That is my output at work. So all of a sudden that was in jeopardy. And I spent a long time waking up going, oh, should I just quit and go to a job where I just have to turn up, do my job and walk out at the end of the day, despite the number of years that I've spent studying and working my way sort of through a career pathway. But then you have some random things as well. So I was someone who every now and again I looked like I'd just jumped in a pool fully dressed. I didn't feel hot. There was no hot flush as such. I just suddenly sweated ridiculously. So I put a spare shirt on the back of my office door and, let people I knew in my, we were an integrated campus, so across 2 institutes, but just to know that there was something there. But again, my particular job, I could do what I needed when I needed to. So I could work from home when I was having those horrible days, and I could sleep until midday and then work 10 hours if I needed to. Or I could have a few meetings, then literally go and sleep in the middle of the day, which so many jobs don't allow. But then you throw in, for so many of us, this is this middle point of our lives where we're balancing work, we're often balancing family, whether that be our own kids or aging parents. Social commitments. I know at one point my kids came home wanting to get involved in something else. And I just said, no, I cannot fathom throwing one more thing in, full stop. And then you sort of also look obviously at the socioeconomic side of things. So, yes, as a researcher with a lot of years of study, don't get me wrong, I'm very pleased with my job, but even still the pathway to get the right treatment for you, and that might be nothing, it might be health and other aspects of fitness. For myself, it was MHT. But even again, with my scientific knowledge, and I went into my GP, I knew the terminology, they were listening to me. I started on a gel, then I had to increase the dose, spoke with a psychologist, so needed a referral to that. Because of my job, I was able to get in on a cancellation 3 months earlier than I would have otherwise. Then I switched to patches, then I switched my dose, then I switched the type. So all in all, it took 9 to 12 months, and that's almost a perfect pathway. And I'm not saying by any means that's what it takes for everybody, but it's a matter of, it's not always an instant fix. So for those people, and I've heard of so many that get knocked back from their GP, that get almost passed around the different specialists. We really need to do better than that. And speaking as a scientist as well, knowing that, when we go through menopause, we suddenly don't have these hormones that have supported our bodies for so long. And it does increase our risk in cardiovascular aspects, in dementia, in diabetes. So the more we can be on top of this now, and longer term, the far better the rest of our lives are going to be, and all the flow-on effect in terms of that. So basically that's why I kicked off Vital, because I thought, if I can't access this information, not saying, as I said, it wasn't my field previously, or not my specific field, but what chances does your average person have? I've got questions in there that I found personal, in that I spent a couple of $100 on new sheets because I could not sleep through the night without absolutely drenching mine. So I had to get new material. And yes, it's a once-off thing, but I was fortunate that I was able to save up and do so. And a lot of people aren't. But then if there are some of those things that we can do to at least ameliorate the effects, then that means we can go and do our jobs, and we can go and do, whether it be family things or social things that we need from a mental perspective, from an emotional perspective, and so on. So Vital is technically the virtual registry of perimenopause in Australia. We like our little acronyms, but I think that was one I was deliberately targeting. It asks a heap of questions, and what it has been set up is in a format that's slightly different. So most research is done with an idea from a clinician or a researcher. Yes, obviously I'm a researcher, but I'm very much approached this from a community member, from someone who's been affected with lived experience. So yes, I've got questions saying, oh, should I be asking anything else? But I really, truly mean it. I want to know what I haven't thought of, because I do know that my experience is different to my neighbour's experience, is different to the person down the road, and is absolutely different to people in different cities and in different situations. So it's not just a matter of what should we be tweaking, but also, you know, throw it at me. Tell me what else we want to be asking, because any condition, any level of care, there are hundreds of questions as a researcher that I could sit down and go, oh, I want to ask this and this and this. I'm, by nature, very curious. In perimenopause, there are so many, but also there is so much that's not done. It's important that if we have a list of 100 potential questions, that instead of just asking the first one being the one that I care about the most, we want it to be the first one that is going to make the most impact for the most people. So it might be 5% change for the vast majority of our perimenopause population. It might be 50% change for a smaller number. And that's what Vital is about. It's about collecting information. It's 100% confidential. You don't have to ID yourself at all. Nothing is saved until you press save at the end. But part of me wanting to ask the right questions and have the right input is also saying, do you want to get involved? So when I first started speaking with people about it, I got some really lovely responses from people going, oh, hey, I heard you setting this up. I've got no idea about perimenopause. I'm in marketing, but is there any way I can help? So in that case, when I got to a point of starting to put the QR code out there, I gave her a call and said, hey, if you have the time, if you're still willing, do you want to be part of this? And I'm not talking in terms of, you know, taking advantage of people, but we all come from different backgrounds. We all have different skills. And obviously the more that we input together, the better it is. But also, again, as a scientist, I know more of those scientific avenues where I can be part of something. So for Vital, I've set up some governing committees where we're not doing too much as yet, because I really want to build that data first. But if you're interested in the mental health aspect, then please tell us if you want to be part of it. If you don't really want to do anything ongoing, but you're happy to share your story so other people know they're not alone, then please let us know that. If you're interested in the women in workplace and menopause policies, you know, there are so many different aspects, and that's what I just love about the inquiry that Larissa's actually got happening, that we can all go in and say this. So it's not coming from the usual suspects, because obviously I absolutely applaud the people that have spent, you know, a lot of their careers, a lot of their lives, whether it's volunteering or as clinicians or as researchers in this field. But I also know how little gets out there to the community. As I said, I was so unaware. I thought it would be in my 50s after my periods stopped with hot flushes, none of which were true, as so many people are aware. So, you know, very much in science, if I only have access to people to come into a clinical trial, I happen to be based in Adelaide. If we only have access to people who do want to, who are happy to identify themselves, and particularly again in this sometimes sensitive questions, not just to do with mental health. Sometimes it might be where you are, sometimes it might be vaginal symptoms, you know, or just you're a private person. But so many things can affect what information is collected. And then also, as I said before, those niches within clinical care and within research and publications can determine what questions someone is after. Are they just wanting to know what people are putting down in terms of symptoms to menopause? Or should we be asking, what symptoms do you have? Could this be to do with perimenopause? Do you know what the symptoms are? Do you have any other conditions that, oh, it could be one or the other? Who knows? Our bodies work all together. It's not as clear cut as saying this is this and that is that. But it's only by asking a lot of people that we can find out that information, and that's very much what Vital is about. And so my exciting new news today is I've literally just launched a new website. It's bespokeclinicalresearch.com.au, and on that you'll find the link to Vital and just a very basic information piece that we used last year at World Menopause Day. But over the next week, I'll be updating that with basically what we've already done in terms of increasing awareness with menopause specialists, with mental health specialists, with community as well. And again, I'd really, really welcome any input and suggestions on that. And as I said, absolutely within the registry itself. My only rule for people to be involved in basically transforming the registry data into improved care is that we're collaborative. So if someone like the marketing person comes to me and says, hey, I want to be involved, I'm not going to go, oh, well, that's not your specialty. I'll be going, how do you think you can help? And obviously still making sure we're doing everything appropriately and ethically. But yes, I'd very much love to get you all involved, and love for so many of you to submit to the inquiry, because every thought, every suggestion, again, it's not one size fits all, and that's what this inquiry is about, so that the government can do as much as possible in this sorely needed area. And all back to you, Larissa. Oh, I think you're on mute.
Oh, there we go. Thank goodness somebody knows how to make the button work. I just couldn't get myself off mute. Sorry about that, folks. Erin, that was magnificent. Thank you so much for giving us your time tonight, and for the work that you're putting into the Vital registry as well as the new website. We had some comments during your presentation asking for the updated link, and I think my wonderful staff member Emma has put that link in the chat, so hopefully folks can get to Erin's Vital registry and possibly also new website. So thanks for sending that info through. And I've also seen, although the chat is sideways for me, so I can't really read everything in detail, but I've seen some wonderful stories come through that people are sharing. I love to hear that, and it really, I think women are really good at solidarity in my experience, and sharing those stories, hearing the experience of others really helps us feel stronger. It helps us feel supported, and it helps us feel like we're not losing our mind and we're not alone with these sorts of experiences. So Erin, I thought you sharing your symptoms was really helpful, and I could relate to a lot of what you said. And there's such a broad range of symptoms, and it's often you start to question yourself, am I enraged? Am I depressed? Am I anxious because of the state of the world, or because my life is busy? Or is this my hormones, having a great old party wreaking havoc on me? And it can really but people who have high pressure jobs, or really just who are juggling all of the obligations in our modern lives, not having that mental clarity that we're used to have, or that level of confidence in ourselves, having that change can really rock you, and it was an interesting comment you made about stigma, because as women we have had to fight for equality, and that fight is still not finished. We still don't have equal pay, and we still don't have workplaces free from discrimination or harassment. So we're still fighting. And I think there's a stigma associated with us revealing our vulnerabilities and the challenges that we're facing. And to that I say, let's be brave enough to reveal them, because they won't be fixed if we stay quiet about them. And the level of awareness by employers, and by doctors for that matter, won't ever be fixed if we stay quiet. So that's the approach I'm taking, although others are obviously free to take their own approach. So what I'm going to do now is hand over to the audience. We've had some wonderful stories, but there's a few comments that have come up early on in the night about the interaction of endometriosis and peri. or menopause. So Erin, do you have anything that you can share or reflect on when it's not just one hormonal thing that you're coping with, but when you've got other medical afflictions, whether it's endo or something else? How does that sort of influence the health approach you take or the care you might need, or how does that impact us? Oh no, and now we can't unmute you either. Hopefully the amazing tech people can allow you to speak momentarily.
Yes, there we go. So I'm not going to go into too great detail because it's really important that we do all recognize everyone is individual. I guess the key things, as mentioned before, is having an awareness of your own body, knowing what is normal for you and what isn't. Yes, particularly as we age, that may change, as if we have multiple morbidity, like comorbidities happening at the one time. Some may come, some may go. For example, with rheumatology, some of the conditions can be particularly affected by the seasonal changes and get worse into winter, which can then make it harder to work out, okay, well, you know, is this bucket A or bucket B or bucket C that's going on? So I would just, I guess, as a personal note, I know even when I go to the doctors, often I'll get there and I'm like, oh, now what was I going to say? So, you know, keeping a journal, it doesn't need to be detailed. Again, dot points. What's normal for you? What do you notice has changed? Obviously, speaking with your particular specialists in your different areas. I did notice, and again, just glancing, that someone's mentioned in the chat that the Australasian Menopause Society has a list of doctors. You can search for them according to state, which is absolutely brilliant. I will say until recently, that has been members of the AMS, as opposed to necessarily saying that they've got a particular level of training. But obviously the fact that they've become members shows that they do have an interest. However, again, everybody is different. So the main thing would be, you know, monitor yourself, have an understanding of what's normal for you, whether it be on a day-to-day basis or across a particular time period. But then, yeah, if you're not getting the care or you don't feel you're being listened to, then please change. And I know that's easier to say being metropolitan based for me than necessarily in other particular areas. But it's incredibly important that we all get the right care. And again, as you heard with me, it can take time to get the right dose, to get the right format. But even though it took me a long while, every step I was getting better. Every step I felt more able to cope with life in general. And then it meant I was more able to go, okay, well, what's my next step in terms of my care as well? And even then, going back with the sort of financial aspect of the inquiry, I know I pushed back some of my desired changes. I knew what I was on wasn't quite doing it for me. I knew I needed to increase my dose or change something there, but I also knew that meant forking out more money for another consultation and another script. So there were times when I waited until I'd either finished my box or finished off my script or whatever. So again, so many levels that we want that input on. Bringing in, whether it be endo, obviously, you know, very connected, or rheumatology, or heart conditions, or so many other aspects, cancer as well. It's still important that you speak with your different specialists, but there are becoming more and more clinicians that are starting to specialize in those sort of merged disciplines. So for example, here in Adelaide, I've worked together with someone who's very much interested in the cardio-oncology field. So, you know, have a look out for them. They're not thick on the ground as yet, but they do exist. And like with diabetes, you know, something that's happening to you, to your body, your hormones are stopping or changing. It's not something, despite maybe the culture we've been brought up in, it's not something that we should be apologizing for, because you wouldn't apologize if you broke your leg, or in the diabetic example, if your hormones stopped working. So it is something we have every right to speak up and to try to change this. because again, it's that thing of, if we can be proactive, and the government and our workplaces, and not just our females, but our partners, our sons, our dads, everybody, if we can be acting so much sooner, if we can know what the heck is going on, if we can find the right answer for us, then that means literally decades of better life for us, better life for everyone surrounding us, and also from a national point of view for the economy, because then we're bringing our skills and our wonderful personalities to the general community, and just making so much more difference there.
What a great answer. And you've really highlighted, I think, the level of the different level of awareness between different GPs. And I'm pleased to hear you say there's sort of an emerging area of interest and specialty in this. But in the previous inquiry that I ran, which looked into reproductive health options and people's ability or not to get a termination if they wanted, or to give birth in the way that they wanted, the info we learnt through that was that there was so little training for doctors on women's health. And that applies here for menopause and peri as well. Like, honestly, it's almost like we're not half the population. I mean, hello. So, I mean, this is like legacy sexism that we will change over the years. But that level of awareness really needs to be there when we train our medical folk, and it also needs to be there in the community. It needs to be there with employers. Everybody needs to understand this. We need to normalise this, and normalise the range of experiences that women and people who menstruate will have. Some won't have any symptoms, others it will be a real challenge. So that was a really good run through. Jody on one of the chats has said, and this is a really good point that's related, why do doctors go to antidepressants first? Do we need more testing in Australia so that doctors are more comfortable to prescribe MHT or other alternatives? That's a really good point. Misdiagnosis, or, oh, you'll be fine, you're just busy, just get more sleep, do more exercise. As if you can invent more hours in the day to do self-care. Like, wouldn't that be nice? What's your reaction to that, Erin, the tendency of some
100%. Yep. It is a matter of, in part because there is obviously a lot of background use and experience with antidepressants. Unfortunately, as I'm sure a number of people have heard, the biggest ever study for hormone replacement therapy, the WHI study, done 20 years ago, admittedly and importantly, done with very, very, well, as would be expected, but very, very old versions of what we now call MHT. But the important part with that is that it was misreported. So for years, the international press has very much made it the devil. And I think that has definitely influenced clinical care, particularly when you consider that there hasn't been this, this level of training that we would have hoped for. I can say, and obviously you tend to get connected with people that are interested in this field, but so many general clinicians, women's health specialists within the primary care, the GP field, your more specialists like for endo and gynae and so on, they're wanting to know more. But even in terms of that education and training, there's more and more places stepping up. So whether that be groups like Don't Sweat It or WellFem, whether it be workplace areas that try to make sure people are aware and can put into place policy. So it's not this big scary thing, either for the sort of the hierarchy or for the people within it. But then also it's a matter of, sorry, I just saw something about the hysterical comment. That's what we're fighting against sometimes. Yeah. And as at an individual level, you might find that if it is a hormonal thing for you, that once you're on the right hormone level or you've adjusted to your lower levels, that you might not need the antidepressant. It is something that reminds me a little bit of back when I was pregnant. I'm asthmatic, and they said, look, yes, it's wonderful taking less medication, but the important thing is that you can breathe. And so particularly when it comes to the mental health side of things, I think the number one thing is making sure that we feel okay. But I do agree that there should be a lot more consideration about other treatments, and not fitness and running, exercise fixes everything. I love running, not necessarily good at it, but it doesn't fix everything. However, I am pleased to say that amongst a emerging area in the mental health and menopause space, so there's people say in the US like Lisa Mosconi, but here in Australia, in Melbourne, the Monash Her Centre, in start of October last year, they launched the first ever Asia Pac Women's Mental Health Conference. So it spanned eating disorders, teenage suicide, a lot of very heavy topics, but menopause was a very big portion of that. And it is about increasing awareness, even amongst, you know, specialists, whatever hat we might be wearing. But it's the fact also, I was very encouraged by the fact that there was so much interest and so many people really delving into this. And the comments that people made when they were presenting were often actually very, very intent, sometimes very personal for themselves, but other times when their patients or friends or all sorts of connections themselves had horrible times, because we don't want it to be dismissed as oh, that's a hysterical woman. No, this is a biological change. We know what's going on to a certain level. We clearly don't understand well enough how it's affecting our body, but our hormones do affect everything from you know, our brains down through the rest of our body. So the more interest, the more we speak up and say, well, that's genuinely great research or great steps forward, but that doesn't actually help me because I have different symptoms, or I'm in a different work environment where, you know, you can't go and sleep in or take a rest in the middle of the day because you have to be front facing, or whatever it might be. That's where, yeah, there's just so much variety. One thing I will mention, there seems to be, when we look back, people that might have had extreme hormonal changes during their teenage years, maybe had issues trying to find the right pill in terms of the different formulations. Sometimes, and this is anecdotal, I haven't looked into the science yet, but yeah, can seem to have either more severe or longer duration of symptoms in perimenopause. And that might just be an indication that those particular people are more sensitive to hormones. But yeah, there is so much we don't know yet. And that's why I love what's happening here.
Indeed, and there's so much more the government can do to facilitate gathering that information, doing that primary data collection, and yeah, making sure that women are entitled to get the top quality healthcare treatment that I believe we should be entitled to, given that we have a wonderful universal healthcare system here in this country. We've had a few really good questions. So there's one from Dave who says, we've got the Medical Research Future Fund, 22 odd billion. How do you access this to support more research now? And Dave, I can tell you that they've got eligibility criteria and people can apply to use that funding. And certainly, you know, you should apply if that's your area of expertise. But historically, we've seen a real underfunding of women's health issues. And let's hope that doesn't continue. And I will flag that on endo, the government did make an announcement, might be 1 or 2 years ago now, of some endo clinics. So there are sort of particular areas of women's health that are gradually receiving more attention, which is good. But we need to make sure that's across the board for all of the issues that we face.
I will just
please add. Yes, go.
Sorry, Larissa. Just to mention, at a broad level, so speaking of the NHMRC level grants that people might have heard of, the ones that you know, are brilliant in supporting your big national levels. And I'm probably not up on this with the latest numbers myself, but it's something like a 7% success rate, and it's based very much on track record. So if you have, with this being effectively an emerging field of research, unless you happen to somehow have decades of experience in this, you're unlikely to actually get that funding when you're competing against other, don't get me wrong, very deserved areas, but like oncology and cardiac and so on. With the MRFF, I mean, that's brilliant in that's targeted, but unless it's targeted towards specifically women's health and perimenopause, we can't even actually apply to it. So it might be an MRFF with a certain thing, but it might be, say, rare diseases and or medical devices. And so something like that, it literally, not only is it not worth putting in, but it won't be considered. So the MRFFs are very targeted. My understanding is a lot of that, the targeting is actually decided by policy and community pressure. And not in a bad way, but just the more people that say, hey, this is important to us as a community, the more that's recognised and the more likely that some of those MRFF schemes can be targeted into this area. As I mentioned, there's a lot of wonderful people literally across the country and across all sorts of specialties that want to make a change, but a lot of them are having to do it basically in their spare time as passion projects at the moment, which doesn't necessarily stop us, but obviously the more that we can get there as a nation, the better we can do.
Amazing. Now, we probably have time for maybe one or two more questions. It's just a bit of a lag when you make your wonderful comments to when I get to see what they are on my fancy Google Doc here. So I'm sorry to the folk that have only just posted, but I'm going back a few minutes now. Eleanor was asking about the level of testing that are done on hormonal pharmaceuticals. And I guess it harkens back to your earlier comment, Erin, about that that sort of sense of, oh, maybe they're not safe. Could you readdress that issue, please? Eleanor's interested in particular about, you know, who they're tested on or what they're tested on, and what any sort of side effects might be. So if you can reassure her concerns there, that'd be great.
Sure. So in a nutshell, when a new medication is developed, it might start back at testing the chemical formula, and that might be something that's been purified from nature or something created completely in the lab. But either way, we want something nice and pure so we know what's going on. But so it's first tested in healthy volunteers to make sure it's safe. Then it's tested in effectively the patient population, or just the population that was likely to use it, in a small number of people, and then in a larger number of people. And it's only when it makes through those stages, which sound easy but are often 15 to 20 years in the process, that then it's released out onto the market. And then it can also have yet another stage where it's sort of post-marketing follow-up. Because even in the last stage before marketing, it might be tested, say, across 1 million people over 10 or 20 countries. And obviously there's a lot of work done to test it in different populations, because we all have different genetics, different living conditions, etc. But then when it's out on the market, obviously the usage goes up massively, which is why sometimes medications on the market will get actually taken off again. There are aspects in terms of the finances, whether the best possible drugs make it that far, because depending on who's putting them through those stages, as I said, 20 years, it can cost the earth. What's available to us as community members is also significantly influenced. So and again, this is my understanding, I don't know all the clauses or the ins and outs, but my understanding is that for a medication to be put onto our Medicare and pharmaceutical benefit scheme, so that we're paying sort of our normal script cost, not something ridiculous, they have to be proven to be equivalent or not too much more expensive financially. So on the one hand, yes, that makes sense from a funding point of view, because obviously we want to provide we want the government to be able to provide as many medications for as many different conditions and people as possible. But the problem with that is that some of those very old hormonal treatments, some of the original ones were purified from horse urine. Fortunately not available anymore.
We've moved on since then, yes. I think.
Yes. But that's the thing, the better the quality that we get, the better safety that we get. Sometimes it's a matter of, well, they are going to cost more upfront, but again, it's about us being proactive. If we're able to take something that's safe and effective early on, and again, I'm saying this in my mid-40s, then it means if we're not developing as much heart disease, we're avoiding the hospital. If we're not developing as much diabetes, we're not then charging or having to use the additional levels of medicines for that care, for the specialists, and so on and so on. So part of the inquiry, part of Vital, part of most research these days is trying to look at not just, okay, well, the upfront consideration is how much it costs, but what is it saving our healthcare system and us? And again, if we can avoid having to quit work or cut down our hours or retire early or whatever it might be, then we need to look at it at that sort of holistic level. So sorry, that is a very broad answer. Again, I will just say, you know, for most people, yes, there's a number of different hormonal options. So whether that be the formulations in terms of gels or patches, whether it be doses, whether it be the hormones themselves, whether it's, you know, the testosterone or progesterone, and there's some that are available internationally that aren't available here as yet. I will say, with her permission, that my mum is a breast cancer survivor, and I know that we've got that in the family. For me, this was the right decision still, not just from the mental health aspect, but from having looked at the science behind it. I will say, if you look at and they don't always come anymore, I think you have to look them up online, but the product disclosure statement, the big piece of paper that we used to get in the box with any medication, that reports every single thing that has been picked up through all those different stages of testing, which is why when you read it, so you just go, oh my. But as came out during COVID, there was actually, and always has been, a bigger risk us being on a normal pill, like contraceptive pill, than there was from getting clots during COVID. But when it was discovered that clots could come out of COVID, there was a worldwide uproar, until we went, oh, okay, well, here's something a lot of the population's been having for decades, and none of us have even sort of blinked at it. So it is a matter of, sometimes it can be very hard to determine that level of risk, which is, again, why whether it's just perimenopause, or whether it's other conditions, whether you're looking at different options that might work for you, do remember you're an individual, you have every right to individualized care, but your clinicians and other support people can do so better with the more information that you're able to provide them about what works for you and what doesn't. And yeah, like with the formulations, it's not always what works for you in terms of the medication working. For me, just the gel was really annoying, and I knew that I wouldn't keep taking it if that's what I was on. So sometimes it's practical matters as well.
Yeah, that's wonderful, Erin. Look, thank you so much for your time. We're going to bring tonight to a close because everyone's got a busy life, and it's getting on to dinner time. Just one last question was asking me what I hoped the outcomes of this inquiry to be. And really, I would just like some federal policy in this space that's based on data and that's based on the lived experience of people who've gone through peri and menopause. So I've got an open mind what those policy levers or legislative changes should be, but I'd like them to involve an increase in awareness in the broader community of peri and menopause. I'd like them to involve an increase in awareness by treating GPs and other specialists. I'd like them to involve an increase in awareness in workplaces of the fact that peri and menopause is real and can affect people in quite severe ways. And I would like there to be developed some appropriate workplace accommodations for that. And I don't have a fixed view on what they should be. Very open to hear from unions, from workers, from employer groups, what they think could work, and that will be different depending on the sort of work that women and people who menstruate are doing. So that might need to be matching the workplace. And I also really want to make sure that any treatments that are appropriate for the person are affordable. And Erin went through some of the hurdles that medications have to go through to get approved to be supplied to people here. But there's also all of these archaic rules about the fact that private drug companies get to decide whether they want to apply to make their medicine cheaper for you. And that just boggles my mind that the government can't just say, no, I want this medicine to be cheap. So I want to find a way around that so that we can actually make sure that people can afford any medical treatment that will work for them if that's what their medical advice is. So thank you so much, everyone. It's just been wonderful. Thank you in particular to Erin. What we're going to do is pop a recording of this session up on the Menopause Inquiry campaign page on our Greens website. There's a link to that I think my wonderful staff have just pasted into the chat. And we're also going to put on that webpage that submission guide that I mentioned at the beginning, which just lists out the terms of reference and gives you some sort of prompters to think about what you might share in your submission, and gives you some gives you the link for where to go to make your submission to upload it. So look, thank you so much for your time, everyone. Stay strong, rely on each other, support each other, and we will hope to bring the full force of the Federal Senate to this issue and to come up with some decent policy, because women and people who menstruate deserve that. So thank you all and have a wonderful evening. Thanks again to Erin. And I look forward to reading your submissions really soon. You've got until the 15th of March, so you've got a bit of time, and the inquiry reports in September. So this is going to be a really decent quality inquiry. So thanks again, everyone. Take care.
Thank you so much, Larissa. Thank you, everybody.